Thank you very much, Simon. Neil, please come and join us. Let me invite Neil Churchill to join the table. Neil is our Director for Patient Experience, and I'm going to invite him to introduce for us the paper on implementation of the Freedom to Speak Up recommendations, whistleblowing. Neil, welcome.
Thank you very much. Karen, did you want to introduce?
I apologise. Please, Karen will set the context, so please, and then Neil.
Just going to remind everyone that as a result of a number of somewhat distressing and high-profile whistleblowing cases in recent times, Robert Francis was invited to conduct a review into whistleblowing, and as a result he made brought his report and recommendations to address the cases and ensure that whistleblowers' cases are properly heard, responded to and dealt with. I'm delighted that Dame Eileen Sills has been appointed as the National Guardian as a result of those recommendations, and we very much welcome her appointment and look forward to working with her along with the other arm's length bodies in the work that we specifically in NHS England need to do. I am taking the lead in this for NHS England itself, and so I'm overseeing the implementation of the recommendations for NHS England as we become a prescribed organisation and have specific responsibilities for whistleblowers from primary care and as well as our own staff, of course. So with that, I'd very much like to ask Neil to talk in more detail about the report. Neil.
Thank you. Just to remind you of the context, building on what Karen has said, whistleblowing has a broader influence on NHS staff attitudes. We currently know from the staff survey that around about 70% of NHS staff feel that they would be confident in raising a concern about patient safety, but that means that 30% do not say that they would be confident in raising a concern, and if they're not, then we're missing opportunities to keep people safe and to give people a good experience. Robert Francis also indicated that people staff in primary care are a vulnerable group because they're working in smaller organisations. It's harder to raise issues outside of the line management structure, and there are fewer outside organisations for them to go to. And that was why he recommended that NHS England become a prescribed body for whistleblowers. And we're on track to get ourselves in that position by the 1st of April when the regulations will start to apply to us. It's important to say that we're already doing this work, that medical directors are already talking to NHS whistleblowers. We've already seen some examples of where we've responded to whistleblowers' concerns, but we need to make sure we're doing that consistently. We're doing that in keeping with Robert Francis's principles, and we need to be able to pull together a central report that will tell you how many occasions this is happening, what kind of things are we doing, and what are we learning. And it's worth saying that this is really the flip side of what we're also doing for patient complaints. The Ombudsman last year produced a set of statements about how patient complaints should be handled. We are implementing those within NHS England, and we're encouraging primary care to introduce those too. So I'd say on the whole we're on track. The main risk for us at the moment is that the reporting requirements for being a prescribed organisation are not yet published, and so we don't know with complete confidence what it is that we will need to collect as information from the 1st of April. So we're working on the 2015 requirements, but we're confident that we will be there and ready when this applies. In relation to Dame Eileen's appointment, I think this is really good news. It's really important we have some coordinated leadership on this across the NHS. The other ALBs are also very supportive, and we've had our first meeting with Eileen already. Worth saying that the CQC envisaged that primary care will be excluded from her initial remit while she focuses on NHS trusts, and we're having a conversation, I think probably in the third quarter of the year, about when she expects to be able to get round to primary care. I think the issues for me really are that we need to have a joined up response, and as Robert Francis has already indicated, that primary care is, staff in primary care are a vulnerable group. We want to make sure that we don't leave them out, and that we support Freedom to Speak Out guardians who are working there. But I'm confident we'll have a timetable from the CQC about when that will happen. It's also important to say that I think from the whistleblower community's perspective, what they're particularly looking at is the introduction of the employment support scheme for current and former NHS staff who have raised concerns and are having difficulty gaining employment in the NHS as a result. We're making good progress. It's quite a tricky area because, as we know from Robert Francis's report, those cases where concerns have been raised are often quite complicated, and there are disputed perspectives about what has happened. But we've had some very good engagement from whistleblowers and from regulators and employers, and we're close to having an idea about how this scheme will work. And I really appreciate the urgency with which whistleblowers want this to come into effect early from April. So that is something that's we're giving a lot of time to at the moment. So that's what I'd like to introduce, but I'm very happy to take questions and give you further detail and assurances needed.
Thank you, Neil. Let's open it up for questions, comments to Neil. Moira?
It's the legal regulatory section. I realise it's not absolutely certain, but I'm interested in the required to report to whom, and what will the role of this board be in that?
We will need to publish a report about the number of whistleblowers that have raised concerns with us, what we've done with those concerns, and how many we have referred on to other organisations. So it's a combination of data and narrative. The Department of Health ran a consultation last year which suggested that there might be some flexibility about how that report came together, and what we suggest is that we would combine the whistleblowing information with the patient complaints information, because this is basically about how good are we at listening to people and acting on what they say, and there will be learnings from both sides. So we're hopeful that we'll be able to produce a single combined report that covers both of those, but we are awaiting the confirmation of the regulations to make sure that that will be possible.
I think it's just that, sorry, if I may, it is important that this board takes a view of that, obviously, but the culture change and the culture setting is much more important. So even if it's in reporting terms part of another report, we would want something that, as it begins, gave us food for thought, really, and tried to ensure that we were shaping it as well as we could.
Margaret?
Thank you. I really welcome the fact that NHS England is seen as the prescribed person because of its independence. I think what's going to be very helpful to whistleblowers is actually getting a response back about what actions are going to be taken, because I think it is necessarily a very isolated position that they find themselves in. And so part of what is important about the role of NHS England in this process is the fact that it's a sort of backstop response, and it would be useful to see what formality there is around making sure that individuals feel supported.
So I think there's a number of dimensions to that. I think in terms of telling people what we have done, we certainly do need to do that. I know that medical directors and nursing directors who are handling these calls at the moment make every effort to do that. There are often some restrictions about how much we can say, but nevertheless, I think there's lessons that we can learn from other sectors where people are already prescribed organisations. So we're talking to the CQC, we're looking at financial sector and others to learn from that. In relation to support that people get, Robert Francis was very clear about people having access to a range of things like mediation where appropriate, and we are issuing guidance for primary care about how organisations in primary care can support people, both by indicating where can you go externally, but also looking at what kind of things need to be available to make sure that relationships don't deteriorate and that people don't find themselves unable to continue to work in a particular practice. I think the nature of that and how it's provided will vary because you've got such a diversity of organisations in primary care, from quite big ones which are well federated to very small ones which aren't, and so we're going to have to, I think, work to build up that capacity over time, but that's certainly something we're addressing.
Neil, when you introduced the paper, you talked about the whistleblowing in the context of patient safety, and of course that derives from Robert Francis's report, but whistleblowing doesn't always fit exactly into one particular category, and it may coincide with complaints about, let's say, financial irregularities in an organisation. How do you see this working across the broad array of whistleblowing instances in primary care and within this organisation? I
think we're trying to make it simple. When, as you say, there are a number of different dimensions to it. I think that there are different places that you would go to report fraud or a concern about patient safety or a concern that services are not good enough to meet the needs of patients or carers. So I think you're right. There are a number of initiatives at the moment which are a little bit of a patchwork. So you've got the whistleblowing work, you've got the patient complaints work, there's some recent work that ministers have started on bullying, we've got learning organisations, and I think that there is a challenge to all of us about how we tie these together, and there's a strong appetite from NHS organisations to tell a simple joined up story and make it really clear to people about what they need to do. And I don't think we've succeeded yet in doing that at a national level, but it's certainly on the agenda, and we're looking at ways which basically this is about how do you listen to people, how do you act on what they tell you, and how do you report back what you've done as a result, and we need to do that consistently. There's more we need to do to get this right.
And simplifying the channel and the advice and support for those who wish to speak up. That's a critical part.
Yes, I think just on that point, we want to make sure there's no wrong door at NHS England. At the end of the day, the people who will be dealing with whistleblowers will be very experienced people who have done this for some time, but whistleblowers, as we know, can contact us in a number of different ways, by email, by telephone, through the contact centre locally, so we need to make sure that there's no wrong door, but our response is consistently good.
Victor, sorry.
Moira made, actually. I think this is quite a challenge, actually. This is quite a significant challenge because you can have as much structure as you like. It's culture that will make the difference, regardless of how many doors there are. So I suppose the question I have is what OD support is there for actually supporting the culture shift, and what part does the board have in keeping that live? Because otherwise we'll just have a set of dials but no way to move the needle.
Shall I? I mean, just for NHS England, clearly I'm here for NHS England, and it's even more challenging for primary care to answer that question. So I can't really answer for primary care, but we'll be certainly discussing these sorts of issues around the board that oversees this work with Ros Rowton's representative David Geddes, who works on primary care, to make sure that we tackle those. For NHS England, of course, we see this as sitting alongside our work on bullying and harassment and other types of interventions around staff engagement and management skills more generally. So it absolutely needs to be connected with those areas of work to address the underlying culture issues. And as we've discussed, Victor, I'm very keen to do that.
Are we working in partnership with the Workforce Race Equality Standard? Because there are some...
Yes, absolutely. So part of our engagement work within NHS England absolutely addresses diversity and the work that we need to do around that. So it's part and parcel of the same piece of work, yes.
Margaret?
Can I come back on the point that you made, Chen? Because I think that it's absolutely critical that the simplicity of the structure is made public. So, in fact, some sort of ownership chart for the various strands. Who owns the fraud complaints? Who owns the clinical within a specific sphere? The HR complaints and so on. So that it's very clear that there is actually a structure that one can see. And I completely recognise that it is much more a cultural than just a physical paper OD issue. But I do think that the chairman's point about seeing something that recognises that there, albeit there is no wrong door, that there are specific channels so that certain types of complaints land in specific places is really helpful to everybody within the system.
Yes, so we have that from us, and I can share that with you. I think the other thing to say is we're working very closely with Public Concern at Work to get our policies right and our communications right, and they're going to be coming in to help with some briefing and some training for people working on this, and they've got a lot of experience from in other sectors as well as from the health sector, so we'll be there. I think the wider system is a bit more complicated because we will be prescribed for primary care and not for NHS Trust. I think that's right, but I would expect that we would have quite a few people come to us who we will then signpost on to other organisations, but we will be able to tell you how many people we're doing that for in the data that we provide to you.
Thank you.
David? More an observation, really, but all of this is critical, and senior ownership, your own, Malcolm, sort of responsibility as sort of overseeing this for the board, the fact that people know that that this is taken seriously is all important. But we mustn't forget that what we should really be encouraging is our people to feel that they have the confidence to be able to talk to their line managers about concerns. And therefore, alongside this, Karen, I would hope that we're having support and interventions in place to help line managers understand that this can be some of the most valuable feedback they get, and it shouldn't be seen as sort of critical, and also to encourage people to raise their concerns first and foremost with their immediate line manager, and indeed up that line, with this as a very important safety net when people feel that doesn't work.
Yeah, David, you're absolutely right, and I do see, that's why I do see this as very, it needs to be looked at as alongside our own work on bullying, harassment and management skills. This is part of what managers should be doing with their staff, and creating the culture in their teams for people to raise concerns in an effective way. So I completely agree with you. That's some of the work that we'll be doing.
And we should have a pretty low tolerance
Yes.
for behaviour that suggests that is symptomatic of bullying and harassment. And
Yes.
I think it's important that there are the mechanisms in place through the engagement survey, through the barometer, through our own understanding, to be clear about what we expect and
Yes.
also what we will not tolerate.
Yes. Yes.
Because I think there's nothing sends signals better than taking action.
Yes. No, I completely agree with you. I think we do need to do, and as part of the implementation for the Whistleblowing Act in particular, or the whistleblowing work in particular, some quite considerable communications around our organisation, and that's our real opportunity to make it really clear what we expect of staff, of managers, as we go to implement this work.
And for people not to be to see conversations about people's concerns as being a real opportunity to learn and develop and improve the environment, not as a threat to
Yes.
themselves, is at the core of it.
Yes, absolutely.
I mean, that's so important culturally for ourselves. It's around primary care. The culture change that we can help to lead from here is probably more challenging, and working with partners to be able to bring that about. But I think the existence of a clear channel for speaking up through to us at this board across primary care is going to be a very important first step. Are there any other questions, comments on this? If not, may I thank Karen and Neil. Thank you very much for joining us this morning.